My name is Georgios Tsvigoulis. I'm a professor of neurology in the University of Athens. I'm also vice president of the European Stroke Organization, and I'm interviewing Andrew Bivard on an exciting trial regarding the use of Tenecteplase versus Alteplase in the mobile stroke unit settings. And I would like to ask you if you have evaluated the number of averted thrombectomies among the 40% of patients with large vessel occlusion that you had in your trial study population. So my question is if the number of averted thrombectomies were higher in the Tenecteplase group compared to the Alteplase group.
Yeah, and this will be the subject of a follow-up paper because it wasn't part of our predefined clinical trial. But we did see an increased rate of clot migration in patients treated with Tenecteplase, suggesting that there will be a number of patients who do not then need thrombectomy.
Another question is related to your very intriguing finding that, to the best of my knowledge, has never been previously reported, the faster onset to treatment time with Tenecteplase. Do you have any insight regarding potential explanations for this finding?
Yeah, it is quite interesting. And I think it relates to the practicality of a single bolus drug, which is Tenecteplase, compared to preparing a bolus and infusion kit, which is a delivery of Alteplase, because you do need to follow up the bolus with the infusion pretty quickly. So you need everything together. And you also, on the mobile stroke unit, the Melbourne model, they're using infusion pumps as well, which takes time to set up, calibrate, and get ready to infuse with the patient. So I think all of these elements came together to result in an overall significant improvement in that time to treatment.
Okay. Another question is the rate of stroke mimics in both your Tenecteplase and Alteplase arm. As you already mentioned, Tenecteplase is given bolus, and there might be some theoretical concerns for a potential stroke mimic treated with full dose of thrombolytic compared to the infusion of Alteplase that takes 1 hour. So what was the rate of stroke mimics? Were there any safety concerns in these specific subgroups with both Tenecteplase or Alteplase?
Yeah, so in the trial, the rate of stroke mimics was less than 10%. And what we saw in the trial was that there was no overall safety indications about this, but it does need to be taken with a bit of caution because the overall numbers are low.
Okay. Then another question related to the thrombectomy group is was there any difference in the number of passes in the Tenecteplase group and the Alteplase group required to achieve reperfusion? In other words, were patients treated with Tenecteplase were more likely to achieve reperfusion with a fewer number of passes or even with 1 pass compared to Alteplase?
That's a great question. We haven't looked at that just yet.
You reported 0 cases of symptomatic intracranial hemorrhage, both in the Alteplase and in the Tenecteplase arms. And my question is, what was the rate of asymptomatic intracranial hemorrhage in both groups?
So asymptomatic hemorrhages occurred in 4 patients treated with Tenecteplase and 5 with Alteplase. These were generally small hemorrhagic transformations, but there's no significant difference between the 2 study groups. But again, numbers are low.
Okay, my final question, I'm sure it was reported. I just want to double check that the Tenecteplase dose was 0.25 milligram per kilogram, correct?
That is the dose of this study, yes. Yes.
And finally, did you have any issues with conducting the trial with regards to the shortage of Tenecteplase in Australia? In Greece and in other European countries, we're giving Tenecteplase off-label in large vessel occlusion patients, and you know there are also trials conducted in Europe, but these trials were hampered with regard to the shortage of Tenecteplase and the availability of the drug. Did you have similar limitations in your trial?
We were concerned about that, but the shortage of Tenecteplase never actually affected our clinical delivery of the trial. So we were very lucky in that sense. We were able to avoid that problem.
I really want to congratulate you on conducting a very important trial. Your recruitment rate is fantastic. You had a recruitment rate of 64%. Did I recollect correctly from your presentation?
That's correct. Yeah, the mobile stroke team were really onto the trial. It's fantastic.
This is an amazing recruitment rate. This further underlines the importance of conducting trials in the MSU setting, because we can have very good, high quality randomized data with an amazing recruitment rate, and we can have solid responses to our scientific questions in the pre-hospital setting. Thank you again, and I'm hoping that this trial will be published soon in New England or in another journal of your choice.
Similar journal. Thank you very much.
You're welcome.